Right. So now we shall start the panel discussion by the first question posed to Dr. Sohrab. This question is from Dr. Bhandari, and he would like to know whether there's any adverse effect if we co-administer influenza vaccine with meningococcal vaccine.
Well, while reviewing the data from CDC and mortality, morbidity weekly report, they only mentioned about co-administration with PCV13 and DTAP, especially in those high-risk group. With others, they don't mention. I mean, the data from CDC or FDA or other countries.
So unless we are suspecting some high-risk groups, we can go ahead and co-administer. Right.
And there is also
just to add on to that.
Yeah, Dr. Danish.
Yeah, just to add on to that, especially with the pneumococcal vaccination, they found that the febrile seizures is slightly increased when you co-administered with influenza, which I presented in my slide. But having said that, there is no contraindication. They said that the risk and benefits are far too high compared to the risk, and you should still go ahead and vaccinate, especially along with the co-administer with influenza.
In relation to that, what about a child with febrile convergence, history of febrile conversion? Would you still go ahead and give him Menactra, Dr. Sohrab?
Well, they have not mentioned any contraindication in the children with febrile seizure. Only this is comes with the combination of the measles and quadrivalent measles, that increases the risk of this thing. In this, I was reviewing this thing. They haven't mentioned that you should not.
So meningococcal vaccine can still be given.
Okay.
And it does not cause fever in most of the cases, right? Or
well, this is usually safe vaccine, like other vaccine, mild fever maybe there, but they haven't mentioned that this causes febrile seizure and don't give contraindicated. They haven't mentioned this. Just as a pain, redness at the sites or mild fever, these are the usual contraindication they put. Otherwise, no.
So the second question from Dr. Rafia. I think, Dr. Danish, you partially answered, but I think it's very important to repeat. Is it enough to give 3 doses of PCV13 like the new schedule in Dubai now, which we are adopting, the 3+0? So I think, highlighting this is important.
Yeah, see, as I mentioned, there are different kinds of a schedule. Even WHO acknowledges that there could be 3+1, 3+0, 2P+1 kind of a schedule. But this is all depends on, the country's epidemiological survey about how this, which schedule, with this schedule, were they able to reduce the incidence of invasive pneumococcal disease, where there been any waning immunity. So based on that, the countries take decision in their national immunization program that what is a kind of a schedule that is suitable. So to answer your question, the NIP here is suggesting 3+0. And I think, and that is also an acceptable schedule and an advised schedule by WHO as well. And I don't see any reason to be worried about it.
Doctor, any idea, like after how many years there is revising and rescheduling of revising of data, like every 5 years or?
See, I think
each country is different.
I think it's a very difficult question. I think, if you look into the most of the studies which I showed you in the Belgian, where they changed from PCV10 to PCV13 to PCV10, and then went back to PCV13. If you look into that, the 3 to 4 years, around 5 years is what they have probably looked into it. I think that is a decent amount of time. I think it again, if you have a sudden outbreak of the disease or something, then probably, I suppose, they take the decision earlier.
Right. Related to that, there is a question, though the doctor has not written his or her name, is that what would be the PCV schedule recommended by you in case of people who have recently moved to the country?
See, again, I discussed about the catch-up vaccination schedule in my slide. It depends on the age, number one. And number two, it depends on whether they have partially immunized in the past. So based on that, so under 6 months anyway, it is straightforward. We go for the national immunization. Between 6 months to 12 months, we go for 2p+1. Over 1 year, we go for 2 primary doses, 1 to 2 years. And then after 2 years, there is 1 primary dose. So I don't, advise to memorize. It is easily available on the CDC website, Red Books. Just follow it, because it is otherwise, it will be very confusing. So even for me, if I had to find this kind of a situation, I always refer and look into the recommendations and then and give the vaccination. I think that will be more, in that way, it's more safer.
So basically, whether they recently moved to UAE or not, depending on their current immunization status, you will take it from there and follow the same schedule as recommended for any other child in this country.
Yeah.
Correct? So, yeah.
And 2 questions about meningococcal vaccines for Dr. Zohrab. What is your recommendation for meningococcal schedule, and what is the earliest age you advise to start vaccinating? And what about Dubai's new changes?
As you saw, WHO, CDC, FDA, European Commission, Australian, all now the data have shown 2 peaks are there, one in infancy, especially less than 1 year, and second peak in adolescent. They are finding that disease is more severe, especially in infant below 1 year. So now the focus, all attention is to bring the immunization to infancy. As I mentioned, there are 3 vaccines. Earliest is 6 weeks, then tetanus toxoid conjugate from 2 months. Let me, because of confusion is there, because people, 6 weeks is 9 weeks, 2 months is Menvio, and 9 months is Menactra. As I mentioned, for 9 weeks, 2+1, for Menvio 3+1, and for Menactra from 9 months 2+1. Now the focus of attention is to start in infancy, and inshallah soon we will have implementation in UAE, also in Dubai. This is a good news, because they are finding, if you vaccinate children in infancy and you give them in adolescent, you protect them. These are the 2 vulnerable age group. In near future, I think all, especially in Middle East country, I think in infancy they should start. Of course, the type of vaccine, the cost of that, the frequency of vaccination, these are the factors one can decide on them, but the earliest is 6 weeks.
Right. There is a related question where they doctor wants to know, how would you choose one over the other? Is there anything to go by?
Well, as I said, one is cost, availability, cost, schedule, number of vaccine given, and efficacy and persistence. As I mentioned, for one is start from 21 months according to the CDC in America to 10 years, which is just published on 29 June in 2020 in Journal of the Vaccine and Therapeutics. So with one, it goes for 10 years, the other one 5 years. So these are the factors that the pediatrician should decide on which vaccine to be given. I'm not mentioning which, this is the decision of the pediatrician to decide.
Okay. There is one question by Dr. Saida and Joom. I don't know if it is a pediatric or obstetric question. So can meningitis vaccine be administered in first trimester of pregnancy in people going to Umrah or Hajj?
Well, in the CDC, I mentioned there is no contraindication with pregnancy. If there are no other, that factor, it is not contraindicated in the pregnancy. This is what CDC and MMR and they are mentioning.
Well, there's a question, doctors, again, not written his name, asking whether we should recommend meningococcal vaccine for all the children. I think it is important to specify this.
Yes, as I said, now, because in Saudi they are giving, because of the lot of data there and this thing, as I said, soon it will be started here also. The data which we have shown from WHO, from CDC, I mean, from all valid sources, indicates that infants need, because the highest incidences in infants and the other vulnerable group, we have to vaccinate. And soon all, vaccination, I think will start from the early infancy itself.
Regarding
so we should do
influenza.
away.
Oh, yeah, Dr. Kalpan.
No, I was just saying that probably we should do away with the term optional vaccines, which tends to create a lot of confusion in parents' minds. And at least as healthcare professionals, we should not be using this term. Rather, we should educate them about the importance of each and every vaccine as they come to us.
Yes.
But now since it is starting at 15 years, and not given in the government at infancy. So I think also it creates some confusion. Unless it is in the government schedule, I think still it will be a little bit, there will be some confusion and hesitation.
May I answer the question? See, earlier when we started chickenpox, pneumococcal vaccine, rota vaccine, they were not in the schedule. They were called optional. But these are all included. I mean, to my opinion, all these vaccines, as mentioned by authorities, are recommended. Sooner or later, all will be implemented depending on the situation and the condition. But what data we have shown that it is necessary, as in the past we have seen the case of rota, in the case of chickenpox, pneumococcal vaccine, and all these were all optional before.
Okay.
Right.
So there's a question about influenza vaccine, whether it's, if the child has taken this one, will he or she get the seasonal influenza?
Influenza, today we are
Protective,
not discussing
60%, I think, protection.
Influenza. Is it if it is related to the conjugate vaccine, it's okay.
Okay.
No, anyways, no, every vaccine has its protective efficacy. It's never going to be 100%. So there's still a possibility that you give the influenza vaccine and a child subsequently gets influenza, maybe to another strain. So yeah.
Because again, the
that.
influenza vaccination is released based on the circulating strains in the last year. So there is not necessarily that, if there is an antigenic drift, then probably your vaccination may not be fully effective. That is something we have to tell the parents, because what happens is, they'll say that we got the influenza vaccination and then we got the influenza. You can still get it because it is based on the last year's strain.
Yeah. There are a couple of questions on interchangeability of PCV vaccine. Dr. Atish would like to know that if you started with PCV 13, but due to cost factor, parents want to go in for PCV 10 from the next dose onwards, is it okay to do so?
See, ideally with standard recommendation for any vaccinations, once you start with one particular brand or a company, it is advisable to continue and complete with that core of with the same brand. But again, I don't think there will be because this all has to be backed up by the studies, that what happened, what was the immune response that you developed with because if you look into the conjugation which is used in the PCV 13 and PCV 10 are different. PCV 13 is conjugated with the CRM protein. PCV 10 is conjugated with a non-typable Hib vaccine. So the immune response may be different. So it may be very difficult to say whether the patient or a child will develop an adequate immune response when you interchange the vaccine. But that is one part of it. And the second part of it is, irrespective of even if you get one dose, there is some response. If you give second dose, there is some response to the vaccination. When you complete the full schedule, you get the maximum response. So no child should be denied of any vaccination, even though if it provided partial benefit. To change of the vaccination, we will need the data. So answer to that will be, we don't know. but that should not stop from giving the vaccination that is available.
Yeah. So, however, quite often it's not only the cost factor. Sometimes it's the unavailability. So it's rather we would rather cover for those 10 serotypes,
Absolutely.
even if PCV13 is either not affordable or not available. I think that's important. Yeah. So I had a question, Dr. Dinesh, about the PCV15 that's in the pipeline.
Yeah.
Any specific reason why the serotypes 22F and 33F were chosen for this?
No, it is just basically, it is. So basically, all depends on the invasive pneumococcal disease that occurs over the course of time. So historically, if you look when PCV7 was there, the 3, 19, and 6 were one of the aggressive serotypes which were causing invasive pneumococcal disease. Although that brought down the incidence of pneumococcal disease, but it didn't stop it. So that's when they went on to extend and include other 3 serotypes. So similar way, if you saw from one of the epidemiological data which I showed you, we have not completely reached to the bottom of the pneumococcal disease. So non-vaccine serotypes are still the highest contributors of pneumococcal disease going forward. So maybe perhaps they've identified these are the 2 significant serotypes so far. So maybe that is the reason they're targeting for those serotypes.
Right.
Dr. Zahrab, any relation with the Guillain-Barré meningococcal vaccine, or the person who has previously Guillain-Barré should not be vaccinated?
Well, I didn't come across, they haven't mentioned that particularly meningococcal causes Guillain-Barré. No, I didn't come across. I mean,
there's one question about COVID. I don't know if you want to answer. We are concerned about COVID vaccine. Is it promising or no? So I don't know. I think nobody will be able to answer.
Let it come and let people get the vaccine data come, and then we will come to know whether it is good or not. It's too early to comment on that.
Okay.
Right. About contraindication to giving PCV or giving meningococcal, if both of you can highlight, what are the contraindications? Very often for minor issues, children have been denied vaccinations.
One was in the children with Escherichia HIV, that conjugate meningococcal with diphtheria toxoid should not be given because of the severe infection with pneumococcal. So the recommendation is to give first 2 years pneumococcal. After completion of the pneumococcal, 1 month after that, then you give this. It is getting below 2 years in this particular group of people. Otherwise, only age below 6 weeks should not be given. And after 6 weeks should be given this.
Yeah.
So with respect to the pneumococcal, there is only one contraindication. That is, you have got a severe allergic reaction to the component of the vaccine. That is, if you have taken the vaccination in the past and you had a severe allergic reaction. Apart from that, second one is not a contraindication, but they say, postponing it, especially if you have, if they say moderately, if you are unwell, not a mild illness. If you are quite unwell, then probably you should postpone the vaccination.
Of course, this is this holds good with all vaccines. Yeah. When child is severely ill or is having fever, because in that case, immune system is engaged somewhere else, cannot respond to the vaccine. So when the child is having high-grade fever or child is ill, immune system cannot handle the vaccine. So better not to give the vaccine, wait, let the child become okay, then to give so that the immune system can handle.
Yeah. And I think CDC also mentions if the child has had a severe allergic reaction to DTAP, any DTAP, then PCV you should reconsider.
Yeah, because it is a CRM diphtheria conjugate, which is the carrier protein.
Absolutely. Yeah. Can premature babies be given PCV? If yes, at what age?
Yes, premature babies can be given PCV. It should be given at their chronological age. So when they achieve their 2 months, they should be able to give the vaccination. But only thing, some studies where they have told that they will have a little risk of apnea, especially if you are less than 28 weeks. So you need to be a little bit careful and cautious, especially when you and advise the parents when you're vaccinating this group of children.
Right. There was a question about availability of the polysaccharide vaccine. Earlier, it was very easily available, and nowadays we're finding it difficult. So somebody asked whether it's available in UAE.
No, even I struggle, and we had one patient where we had to give, and we had to send it to one of the government's sectors to get the polysaccharide. It's not that easily available in the private sector. And then nowadays, as you can see in the CDC recommendations, elderly more than 65 years should get a polysaccharide vaccination. So that is another recommendations. I don't know how there will be an availability of that vaccination. That is another question. Which remains unanswered, yeah.
But the one thing I wanted to mention, just recently, last month, CDC and Mortality Morbidity, they released a report, 40 pages. I recommend all pediatricians, I can share in the group. In that, they have mentioned everything, I mean, especially about this meningococcal vaccines, everything, the latest, just 1 month back it has come, the latest informations are available. I will share in the group, I mean, those who are interested to have, because this is the latest from the authority, CDC and the group, they can read the guideline.
Now, babies who are accompanying their parents for Hajj, if the baby is less than 6 months of age, would you be vaccinating the child, Dr. Saurabh, for Hajj purposes?
Yes. As I mentioned, this also is mentioned by CDC also. Those are, I mean, let me first, before I say this is very important, because parents, they come to the clinic, we want to go to Hajj, you please give vaccine. When you want to go, after 5 days, after 3 days, please. In the DHA, there is a section called the vaccination of the children for Hajj. There categorically, they mention, please, at least 2 weeks. I mean, minimum 10 days, but preferably 2 weeks before going vaccine to be given so that it, causes immunity. So this, I would like to request my colleague pediatrician to advise the parents, those who want to go for Hajj, they should be vaccinated at least 2 weeks before. Now, regarding that, yes, both CDC and all authority mentioned those who are going for travel from the 6 weeks, they can start vaccination. Earlier 6 weeks, we have 2+1, 3+1. Of course, after 9 months, you can give other. The earliest is 6 weeks. They can get vaccination.
Dr. Zahra, from your talk, we noticed that only Niemann-Rix has 10 years like study for effectiveness of the vaccine. So if one is having Niemann-Rix or had Niemann-Rix, let us say 6 years back, and is going to an endemic area, do we advise giving or not giving because of the new data?
Earlier data was 5 years, both internationally and UN. Now, just on 29 June, they published that they have found 10 years persistent is there. I mean, academically, 10 years is there, but the country, sometimes, you know, the country who is receiving the, the passengers, they may not consider this thing. They won't just resent. But academically, yes, if suppose you have given, suppose after 1 year, the other dose is in adolescent. This is what academically said. But the rules of those countries for getting the, the travelers, that depends on the countries, whether they consider this academic, the papers, published papers, that depends. But 5 years, from 21 months to 10 years, data is available for different vaccines.
Okay.
There was a question by Dr. Nasma saying that many people in UAE are not permanent residents. So if a child had followed UAE schedule for pneumococcal vaccine, that's 3+0, what will be the situation when going back home when his home country follows 3+1 schedule? Should he receive a booster dose?
I think, it all depends on the countries epidemiologically. Incidence of IPD. So that's where they come up with the kind of the schedule. I think, there is no right and wrong answer to this kind of a question. But I think one should perhaps follow what their national immunization program is in the respective countries where they're going to stay. But
Absolutely.
again, even let's say if still they didn't take it, but still, both schedules are valid. 3+0 or 3+1 are both valid. But ideally, one should follow the NIP of the countries they live in.
Yeah, I think that cannot be stressed more. I mean, in all our vaccination webinars, we have been talking about this, that vaccination is region specific. So that is why the schedules differ. And that we have to follow, if the child is going to stay there, whatever is the local schedule has to be followed thereafter. So if he requires one dose, or if it is recommended to give one booster dose, so be it. We should go ahead and give it. Yes. So interestingly, you have highlighted two serotypes, 6A and 19A, which are related with antibiotic resistance, either to penicillin or to the other antibiotics. And I was just wondering, in those of our cases that are, not responding, going on to empyema despite being vaccinated, is there any role for us to know which serotype would have caused the disease? Just an academic question.
I think that's a very good question, Dr. Kalpana. I think that is very, very important. And that is the need of the hour in any country. See, when you get this invasive, so-called the invasive pneumococcal disease, they should always be typed. And because it is important to understand from the epidemiological point of view, and to see, is there any further serotypes which is causing this kind of a things. So unless and until you have that kind of a report, you probably wouldn't be able to, understand which serotype, or is it the vaccination serotypes which cause the invasive disease, or the non-vaccine serotypes which cause the disease. Again, it is interesting that what is happening nowadays is when you again, one has to consider that these vaccines are not 100% protective. If you look into all the data, the IPD incidence reduction is to the tune of around 80%. So still there is a 20% of that population who are still risk for invasive pneumococcal disease. That is number one. And number two, a patient who is still again fully vaccinated gets an invasive pneumococcal disease. As I mentioned in one of my slides, you have to think outside the box and think about whether are we dealing with some other immunodeficiency condition, because that should also be taken into consideration.
Sure. So the complete picture is important. And I think for, like you said, for local health authorities to make any strategies, any planning, to know what are the serotypes in circulation, and also to know if they are vaccine serotypes, then there is an issue with the vaccine coverage. These all are important to know. This local data becomes interesting and important. Yeah.
Absolutely.
Dr. Danish, also there is a question about the PCV vaccine for healthcare professionals and doctors, like above 40 years of age. Do you recommend, which type do you recommend? PCV 13, Prevena, or anything about this, about healthcare professionals?
I think Dr. Pankaj has asked.
I think the CDC before was suggesting PCV 13. And then now they're recommending that after 65 years, you just need a PPSV 23. So why they made this step is, when the patients were given the pneumococcal vaccination, the conjugated pneumococcal vaccination, the kind of the invasive pneumococcal disease the elderly population were getting were from the non-vaccine serotypes. So the PCV vaccination, which either they got it by vaccination, the immunity that the non-elderly population achieved either by vaccination or by a herd immunity, was protective for all the serotypes, all the vaccine-associated serotypes. So this is the beauty of the pneumococcal vaccination. It not only gives the protection against the vaccine serotypes, but also provides herd immunity. So because there was an increase in the non-vaccine serotypes in elderly population, then that's why the CDC said to change from before, because they were suggesting both PCV 13 and the PPSV. Now they're telling that PPSV 23 after 65 years is enough.
We have winners also, winners of the...
Yeah, I think we have covered most of the questions. Is there anything else, Dr. Bushra? I think vaccination is a never-ending topic. So right from beginning, this is, I think, the third webinar of DPC on vaccination, and the questions will not end. But it is good to keep revising and reiterating the important points.
Can I give one announcement?
We can, I mean, the questions also can be sent to the group, and then Dr. Danish and Dr. Zohrab can answer.
Sure.
And then to DPC.
They've given me the list of the raffle draw winners. Dr. Vasilika Kavadia. Second is Dr. Tasmia Tahmid. And third is Dr. Nobi Koya. Today, like vaccines, the names are also difficult. Really. So congratulations. The prizes will be given to them in the clinics.
I think doctor just confirmed that they are there till the end.
No,
so
it is, we have announced.
Oh, just please repeat the names, doctor, if possible, because maybe they did not hear.
Vasilika, Tasmia, Nobi, Koya.
Okay.
These are the three names. So I would like to give one announcement. I would like to thank Dr. Kalpana and Dr. Bushra for moderating this session on behalf of DPC. I would like to thank Dr. Dinesh for excellent talk and discussion. The announcement regarding the next DPC meeting. Our next DPC meeting will be on 3rd. It is regarding different types of rickets and vitamin D. Our speaker will be Dr. Loay Eid, consultant pediatric nephrologist. On 6th November, we will have a DPC meeting on allergic rhinitis and asthma allergies. Our speaker is Dr. Hanan Al-Sharif, consultant pediatrician and pediatric allergy specialist from University of Sharjah Medical College. Well, on 28th November is our annual virtual conference. The link will be given to you soon. And I would like to thank Pfizer for sponsoring today's vaccine. I would like to thank the Gulf manager of this company, Dr. Mustafa and Dr. Muhammad Rafat, for sponsoring. Once again, thank you very much, Dr. Dinesh, Dr. Kalpana, Dr. Bushra, for excellent talk and discussion. And I would like to thank all viewers. Really amazingly, 2,000 some registrations were there, although all could not come and join us, but amazing registrations we are getting. And thank you very much, Dr. Kalpana, if you want to give the final remarks.
No, I'm just thanking both the speakers, very lucid talks, very well highlighted all the important points. And I think it is good to take 1 or 2 vaccines together and then talk in details. And if after this, if there are any questions, any queries, any doubts still, I think they'll be more than happy to answer those. So DPC would like to thank all the participants for their active participation, and even those who did not ask but listened to every word the speaker said. Thank you so much.
Thank you.
Thank you. And before ending, Dr. Vasiliki is thanking us for the prize. He's one of the prize winners, and he has sent a message.
This clinic, and once again, I'd like to thank all the viewers. Really, they are joining us in all DPC webinars. See you on 3rd November with our next webinar. Thank you very much. Thank you all.
Thank you.
Thank you.
Thank you very much.